Okay, Cindy, thank you so much for doing this. First of all, I was trying to think back to when we first started communicating together, and I think it could be a decade, that feels like a very long time. Um, I don't know if you know my origin story with Scott, with Scott Miller, I had a supervisor when I was probably 2005 to 2009. I was working at an intensive outpatient program in Maryland. And he had said to me, Will, one day I hope you get to see a Scott Miller conference, a presentation. I didn't think anything of it. I thought, who's Scott? And then I started training in solution-focused brief therapy, heard about Scott. And one day in Australia, I think it was about 2012, I was sitting in the backyard in Australia and I thought, Scott Miller popped into my brain. And I said, I wonder if he's ever in Australia. And I looked on his website and he was in Sydney, like a 2 hour flight away. And I found something on social media and I messaged Scott. I said, listen, I'll get on a plane right now. It's Friday afternoon. Can I come to this training tomorrow? And he said, no. And then I stalked him long enough to get a consultation with Scott. And we've been friends and presented together ever since. And it was such a weird synergy. And that brought me to meet this wonderful world of people who are thinking about psychotherapy outcomes and how do we improve people's experience in the services we provide, which led me to uh, talking with you. So, do you want to share just a bit of background about your interest, your passion, how you're connected to this wild world of the research about what makes this work and how can we be better?
Sure. Thank you so much for having me here. I love to talk about fit, and so if I get on my pulpit too much, like tell me to.
Yeah.
And and so this started really for me. I was getting my psychology degree. I wanted to do an outdoor program, and during that, what came out of it was that I was really good with patterns, probabilities, psychometrics, and I was told you should go down that path. And and so when I left, one of the other things, it was this whole idea of informed consent and the relationship, the power imbalance between clients, particularly more marginalized clients. And and so I thought that routine outcome monitoring would be a good solution for that, a way to bring the client's voice in. And I started this company, Holistic Research Canada, because we were really like, we had complementary physicians association. We're looking at, all the different kinds of therapies that we could do with people. And so I developed these measures and this protocol and was doing research. And that is where I came into contact with the person who I worked with for almost 20 years, eventually on My Outcomes,
Yes.
which in 2011 we took over. But for 2 years before that, I had been leading product development on a mental health portal where clients could go in, they could journal with their therapists, and they could take all kinds of assessments and get feedback on what those assessments meant. And they could do the ORS and SRS, and they could see their scores on their own dashboard.
Yeah. Wow. So for those listening, we're talking about feedback informed treatment, which I guess the nerdy definition is uh, we call it pan-theoretical. So it's zoomed out. So it's in many ways feedback informed treatment is agnostic to, let's say, the reason most of us are here, whether you're indoors or outdoors, doesn't matter. What we're trying to do is actually get some data to make data-driven decisions about how we're going to proceed working with this client. So to do that, we typically use two very simple measures that are so deceptively easy. being the outcome rating scale at the start of every session or the session rating scale at the end of every session. That's to measure the therapeutic alliance. Um, so you created, and then taking the two pieces of paper and getting them into software, making it easier for therapists, easier for clients, and to make it easier to store and look at the data. Is that right? What you were doing?
That, I mean, so that really consumed me
Mm.
from
Yeah.
2011 to 2021. And yeah, and I mean, when it comes to feedback informed treatment in particular, that was a lot of what we built out was not just collecting data, but as you said, making data informed decisions. And the decisions are being made, of course, with the clinical therapist, perspective, but also with the perspective of the client, right? And that's this idea of these patient reported outcome measures, and that
Mhm.
we're collecting data using these tools. And the outcome rating scale is particularly adept at doing this because it works with more people because they're creating the anchors, they're creating the items in a way, right?
Yes.
We're asking them instead of boxes to check off that match, something like, have you been feeling depressed lately? um, those kind of tools are helpful, but they often miss out on what it is you're there for and what's really going on with you, right?
I
And
Mhm.
yeah, go ahead. Did you want to add
No,
something?
well, I think this is such an interesting point that I remember I started getting my critical calling bullshit lens during my internship of my Bachelor of Social Work degree because I was working at a day clinic for adults with severe and persistent mental illness. And everything we did was write your case note the right way so that Medicare funds the client. And then I found out we were owned by a pharmaceutical company. So we were holding clients that were just going to wait to take part in the next clinical trial. And so it was this weird, like, are we actually here to help anybody? It was really awful. And you said something at the start of this I really wanted to touch on that using something like the outcome rating scale, I mean, the kids' version of this has smiley faces on it, right? It looks so simple. And you brought up this idea of this sort of social justice as in how we actually measure outcomes, that we often as therapists and in the outdoors this is a real trap that we think the outdoors are so wonderful. I know you love your time in nature as well. And one thing that happens is we think we have to fit clients into the outdoors. Then they'll wake up to how wonderful being around trees are, you know? So we count things related to what we value. And the outcome rating scale sounds like it measures outcomes, but it actually just measures the client's perception of outcome, what they're telling us they want from our work together. And so, can you say a little bit about how we can do this kind of client-driven research and why that's important for shifting the narrative about evidence-based practice, that this is evidence-based practice one client at a time.
Well, I like to use the 10 clients. Okay. So we've got 10
Hmm.
clients, and you are a proficient cognitive behavioral therapist. And
Hmm.
so that means that 5 or 6 of those people that you see, they're going to experience meaningful change, right? That they're going to notice a difference. It's going to show up in their lives.
Hmm.
But then there's the other 3 or 4, maybe 5, right? That it didn't work for them. And that's a lot, right? So that's
Yeah.
people who that's one person who left after the first session and never came back, right?
Hmm.
Not because they got what they wanted, because they didn't get what they wanted. and then two or three more who maybe stayed for a few sessions, but maybe one deteriorated, and the other two, they just didn't go anywhere with it. So they're
Mhm.
wasting their time. They're showing up for something, and it's not helping them. And so having a way to adjust that and to acknowledge that like you said, it doesn't always fit for everybody. That's what these tools. That's what they bring into the therapy room, right? And also because of the questions that you ask them, they're uh, it's almost part of therapy. It could almost be a kind of therapy. I have a book from the UK. They tried to do this in children's services, where they
Mhm.
just went, okay, so personally, you're not feeling good about yourself, and that's not, that's gone down from last time we were here, and then they talk about that, right? And
Yeah.
like that's the therapy.
Mhm.
Um, but you know, it also can just be added in to whatever you're doing,
Yeah.
right? Where and also, it doesn't have to be hard, because if you're doing it and you know that probably five or six or maybe seven or eight of your clients are going to do great, then there's nothing really to talk about. Maybe if one of their scores goes
Yeah.
down, right? But otherwise, move on, right?
Mhm.
It's for when it's not working. That's what it's for. So,
Yeah.
Scott Miller, he always talks about, Bruce, we talk about an effect size of 0.8, and that it has not moved in
It had,
decades. In
yeah,
decades.
since 1977, since our first meta-analysis, not 1% of improvement in therapy outcomes. And that's despite, I mean, one of my favorite papers is the psychotherapy hype checklist from Donald Meichenbaum and friends. And they talk about, if you take like the number of empirically supported therapies from the 1960s, they fit roughly under two camps of the behaviorists and the psychoanalysts. And then if you made a family tree, we'd be at thousands of therapies. And then you add in if it's group or individual. I mean, look at my field. We have adventure therapy, adventure-based counseling, wilderness therapy, wilderness adventure therapy, outdoor behavioral health care, ecotherapy, these things. And we keep reinventing this wheel. And then what happens is we're missing the person right across from us, and we're not measuring what they value, what brings them into the door, why they're sitting across from us.
Yeah, yeah,
Yeah.
so true. And to your earlier experience, when you first started out,
Mhm.
and what you're describing, when you have to fill in forms and write your case notes that doesn't really describe this person, add labels that you don't really feel clinically fit, but you have to, that it's causing moral injury. You want
Yes,
to get rid of burnout? Get rid of that.
totally. Oh, you're preaching to the choir here. That is, I find that to be, if all of that stuff seems antithetical to why all of us got into this world of wanting to be useful to other people. And then all of a sudden, we just have to be useful to the bureaucrats and work the way that they're. And it's funny, living in these evidence-based times, all you have to do is open a newspaper and you'll find someone making an unevidenced decision that will impact clients. Okay,
Yeah.
let's get into the weeds a little bit. So one of the interesting things, I think, for the folks here, we've converted them. We've converted them to become feedback informed practitioners. Now, one of the things with feedback informed treatment is people say, yes, my clients are my best teacher. And then you say, how do you know? And they say, well, I end my sessions with, how was everything today? And then, and I say, what feedback do you get? And they say, clients say, fine, it was good. Just like when we've got a bad haircut. How was it? They hold the mirror up and you go, great, thanks. And you leave. Why is the piece of paper or the systems that you've worked over the past more than a decade to create, such as my outcomes, there's tons of different ways to do it. Why is actually having a system and a framework in place important for the worker?
Well, it reminds me, I'm going to start by telling you about a study,
Yeah,
right?
sure. Yeah.
And I don't remember the name of the study, but it was Scott and maybe Daryl was involved in it, and they had students going over videos for where the therapists asked for feedback at the end of the session, right? And so the therapists are they know they're in a study where they're asking
Right.
for feedback at the end
Yeah.
of the session, right?
Hmm.
And they couldn't find it. And so then Scott and the experts, let us look, let the
Yeah.
experts look. They couldn't find it either. So I guess that's part of the reason why.
Yeah.
Um, yes, and so you know when you have something as simple as a session rating scale that's completed at the end of the session before they leave,
Hmm.
again, if everything's great and you know and everything seems to be fine, then great, thanks, right? We can acknowledge that it's maybe not that helpful right then.
Hmm.
But if one of the subscale scores or the total score is, you know, below the clinical cutoff, or has gone down, or one of the subscale scores has gone down, you might want to talk about that. And if you don't have time to talk about it at the end of the session, acknowledge it,
Hmm.
right? Just acknowledge it and leave it open, and then however you want to deal with that. But at least you're um, creating that opportunity, right?
Yes.
And working, you know, putting on a like more of a corporate hat,
Hmm.
managing people. That's how I manage people, is with numbers and reports. I don't say, you know, I don't think you're very good at doing your job.
Right.
Say, here's these reports, right? And here's kind of the benchmarks for where it should be at. And so it's the kind of the same kind of principle.
Hmm. Yeah. And I think it is drastically simple. And I want to talk about the study we're doing in a little bit. But one of the things is the funny thing is clients do, and I've worked predominantly with teenagers and young adults. And so the younger the child, the more apparent this power difference is. And younger children, especially, aren't used to being able to tell adults, I don't like that, I don't want to do that. And so you have to, there's a piece of paper or a computer program that will help you measure, but it's also how you talk to the clients that get them to fill it out. So one of the things is I remember in a board meeting, on a clinical board meeting for another organization, and someone said, "Oh, I tried to use those the session rating scale before, but clients just lie. They fill it out, they're lying." And I said, "Well, they're lying to you." Like they're not lying to a piece of paper. They don't want you to know what they really think. And one of the things, and this is like sort of the paradoxical of negative feedback, is if they give you negative feedback, they're invested in something. They want something more from you. It's a gift. It's wonderful.
It's a really important piece to include in our discussion,
Hmm.
because it is true. When I was talking about it earlier, I wanted to go there, right? Which is, you know, the therapist says these scales don't work, right? My
Hmm.
client says everything is fantastic, and I go, yeah, but look at their trajectory, look at their progress over time, right? They're flatlining. They,
Hmm.
so you know what? They just don't feel comfortable telling you, and that's one of the statistics that has, you know, has come up, is this idea that if on the first session with them, if you can
Hmm.
get them to give you a score
Yes.
below the cutoff, then you're more likely to be getting an engagement with them. And then it's actually predictive, right? That if that score starts to go up over time, we're also going to see, it's also indicates that their outcomes are going to be
Hmm.
better.
Yeah.
right? So, yeah, and that clients lie to me. Absolutely, I've heard that one a million times.
Yeah.
And
And
so that, I just wanted to say, so, it is about having a culture of feedback. So it doesn't work without a culture of feedback. And so, if you're working in this constrained system, and what happens if at the third session, you try and adjust things, or at the fifth session, it's really not working, and this person's coming back with in earnest, and you don't have any place to send them, right?
mm,
Because they're stuck in this program. Um, right? I mean, that uh, the changes that are needed to the system, um, I hope they come, because I haven't seen the movement, the way that I would expect it based on the massive amount of evidence.
hmm yeah. It's an interesting thing that it in many ways, and this has been a theme in the way I've been thinking over the past few years, that feedback informed treatment and monitoring client outcome is I mean, I'm a convert and I'm a nut about it. I think that there is this, it's actually liberating. It's do whatever you want as long as it's useful for your client. And speaking to negative feedback, I've probably told this story to some of the people in the room before, but I at a school about an hour south from Adelaide, where I am today, disadvantaged school. We took a group of the kids on an expedition, and it was so fun. Um, and it was so good. The school was like, "We'll have you one day a week here. Just keep working with the kids." I said, "Sure, no problem." So I'd go there, and I had a session with one of the young people. We had been on this 14-day expedition, sleeping in the dirt, pooping in the woods, all the stuff that is so fun. And so we have this 1 hour session, and I get to the end, hand him the session rating scale, and he says, everything was good. And then, did you like what we did today? 5 out of 10, and we know anything below a nine is a gaping hole. It's huge. And I said, what's going on? He said, well, it's too long. The session was too long. And I said, really? I was like, it's 50 minutes. This is how I'm trained. Like in my head, I was just all in my own. This is what the textbooks say. What are you talking about? And I had that hour drive home and I thought maybe, oh, I said to him, how long? Like 40 minutes? And he said, 10, 15. And the drive home, I went, maybe he doesn't like me anymore. Like, was I not as useful as I thought? And the next week I walked in, he had gone to school and printed an agenda for our session. And so he comes in and he goes, had a fight with my mom. Should I have called her the C word? I said, no. And he did, yeah, I didn't think so. Crosses it off. And so his negative feedback was actually just, this is how I want to engage with you more.
Yeah.
And so it wasn't a changing by changing who I am. I mean, I'm down with that too, but it wasn't, we weren't changing much. It was, this is what I want. And what happened is probably for the full day I was there, he probably came and had 6 or 7 5-minute sessions through the day. Come up, think about something, talk to me. But it was the tool, and you said the word about engagement before, is that we have this system where we're focused on, well, we're told to be focused on processes, procedures, empirically supported treatments, do this therapy the right way. In the Australian context, everything is funded based on what the worker says that they're doing. And then what we still see, which you said earlier in this conversation, people come for one session, then they don't come back. We know that's the modal number of sessions. Even during initiatives that try to improve access to therapy, more people might go one time. And so we have this engagement problem that people who could benefit show up, feel they don't get what they wanted, and they leave. And it's tempting to rationalize our way out of that by thinking, well, that doesn't happen to me. Well, then it doesn't happen to any therapist, but somehow the data shows that it does. Can you talk a bit about engagement for a second and where we may be getting this wrong from the first visit?
Uh, read Daryl Chow's The First
First
Kiss.
kiss, yeah. Yeah.
Um, well, yeah, I mean, to me, we're getting it wrong by giving assessments, right? I mean, that's my thing. So giving people assessments that ask them questions that are not relevant to them might be triggering for something they didn't come there to talk about,
Mm.
right? And I think mostly that you do a bunch of paperwork and you have to expose yourself before you even talk to somebody. And I think that if we switch that around and we make from the first moment they call in, the first moment they come online,
Mhm.
right? We make that part of the therapeutic process, right? I
Mhm.
just don't know how we get there with these ridiculous systems we have. My wish was that the outcome and session rating scale could have been used everywhere. They were used around the world.
Mhm.
Um, but so that we could collect the data and start operating differently, right? Because you talked about it being liberating. That's certainly how I felt.
Mhm.
I didn't fall under a licensed profession. So I would only do volunteer. I'll volunteer at the cancer agency for a couple of years, right? It wasn't until I found the outcome and session rating scale that I'm like, you know what? This is my supervisor. This is my oversight. And lo and behold, little Cindy was able to get herself a 0.8 effect size and know when it was working and when it wasn't working. And so, it gave me confidence to actually charge people money for my
Mhm.
services.
Yeah. This is such a I guess this is a perfect segue for this question that I had mentioned before we hit record that I in 2022 I started a study with some friends about using these two measures in the outdoors, and we got a small grant. We offered some training with Scott Miller and offered it online to anyone who wanted to come. People came. I made webinars for people. Here's ideas of how to implement this in the field. And a bunch of people signed up. I'd say about 50 therapists in our field, which organizing 50 adventure therapists to do anything is a miracle, right? And one of the things I wanted to do was I knew of so many people working in the outdoors doing really important work who had no clinical training. This is outdoor educators that maybe a group of kids in out-of-home care go on a trip with them. And so we started inviting everybody and anyone doing this work into the study. And at first the energy was on fire. It was awesome. And then slowly what happened is some people lost contact. I mean, this is any research project. People get bored, they move on from things. And then where I'm at now is what's fascinating is I'm working on this manuscript, but we have in the Australian context, all we hear about is the youth mental health crisis and the systems, the therapy services are overloaded, and we can't get people into care. Even when they get a referral, it's still 100 something days in some places to see a psychologist, or being a country that is quite empty in rural communities, you can't get anyone at all. All of us were late to telehealth as well. Um, and there's four practitioners in this study. One of them is in this call, Mark. And the four of them collectively over the last few years have worked with over 550 clients. Like they are pumping through clients, right? And their effect size collectively is over zero point 0.8. They're amazingly effective. And one of the things I put into this study after reading a lot of Daryl Chow's work was actually tracking how often do people call me and ask for help? Or they say, I've got a statement score. A client scored a 1 out of 40 on the outcome rating scale. What do I do? This and that. So they're also the four people in Australia that call me the most. and ask for help with things. Not saying I have the answer, but I wanted to see who's actually most invested in this process. And their outcomes are amazing. And there's Mark giving a thumbs up. That doesn't mean call me all the time, Mark. Actually, call all the time. Mark's actually won. Mark is a school-based police officer in Queensland, and Mark won the Australian Institute of Criminology's Silver Award for Crime Prevention. And so, incredible awards here. So, one of the things I was interested in, you talk about your experience of being a volunteer using the outcome rating scale. Do you find that this just makes more sense to people that haven't gone to social work, psychology, counseling school? And if so, why or why not?
Um, well, I guess I don't quite see it that way. I see it more cross disciplines.
Sure.
The issue is, are you a student or are you an expert? Right. And I think the field, as it sifts through in the education process, right, and you go up and up, the more and more you are that expert type. And I mean, I've certainly experienced this where I'm arguing like someone, a researcher from the National Center for Clinical Excellence, where we're going to use research. And these people with PhDs, it's like their opinion,
Hmm.
because they're experts. So really, that's it at the individual provider level. Uh, if you are a perpetual student, like both of us, right,
Hmm.
then you embrace it. You're curious, right? You're humble, you're open. And if you're an expert, well, either you're an expert, so you don't need it
Hmm.
because you're helping all of your clients, right?
Yeah.
And everything is fantastic. Or that's that to me, that is the problem, is the system cultivates experts, and if this is threatening
Mhm.
to them.
Yeah, absolutely. And so going to what we like being the perpetual student. Yes. And the greatest thing too is um I've always, I mean, when talking with young people, I know if I even remotely try to be an expert, I will, teenagers will call you out in a second. So it's easier to just be an idiot, you know? I'm not gonna guess if you like this or not. I'm not gonna waste your time if you don't like it. You know, I can get your mother to drag you by the ear somewhere else and you can waste your time. Not interested. Um, Now, before we hit record, we also were talking about dose effect, and so this is how many sessions should we wait to see change? Now, this is interesting because, like you said, the system and who tells us how many sessions, it's almost like they've never read anything about dose effect at all. And for historical context, for those listening, we used to, in the 80s, this fight really happened, which was the brief therapists and the psychoanalysts. They were all fighting. Brief said they're faster. The long-term therapist said they're better because it's longer. And the research indicates no difference. That brief isn't faster, long-term isn't longer and more, well, it might be longer, but it doesn't mean change happens faster or slower. Can you say a bit about this research and then what's been your interest lately in when should we expect to see some significant, some meaningful change for people?
Right. Well, this whole idea, back to my 10 people,
Hmm.
right?
Yes.
And those 4 or 5 people that, are probably not going to be successful. Um, Being able to identify that and act on it, that is one of the powers of fit, right?
Hmm.
And oh, what we were talking about before is, um, there's this a recommended best practice. Even Scott Miller, he talks about it, and with the outcome rating scale, it holds true that we can look at the scores on a patient self-report measure like the ORS. And at session 3, we can compare from their intake score to session 3. And particularly when you use the advanced behavioral algorithms in the electronic fit systems, but even just with a good old reliable change index, right? And just eyeballing it even, right? We can predict with some accuracy that if they're not improving by session 3, that they're not going to go on to improve. So the reverse of that is the outcome rating scale is good at identifying early change. It's good at identifying early change because it's based on the person's perception. It's based on their emotions. It's not based on a symptom checklist, for example, right? And did your score go up? And they'll, like, if your score goes from goes from a 4 down to a 3, they're going to say that's good, right?
Mm-hmm.
But it's a lot more clunky, right? With the outcome rating scale, it's a lot smoother to see that. And with other tools, and this is the one I was talking about that I'm investigating right now, like I might present this at a conference in a couple months, is that with the PHQ-9, which is, one of the most common measures, and it's now being recommended, like if you want to get your research published, it's one of the tools that you should be using.
Wow.
And this study showed that it was not able to reliably predict cases that were off track, right? Not showing early change until session 4 or session 6. And the session 4, that was for the extreme cases, right? So, we've got the most likelihood of seeing change when someone is very extreme. So really, it's session 6. So that's a big difference. That if you are doing routine outcome monitoring, measuring either every week or every couple weeks, and you're using the PHQ-9, it's going to take longer. It's likely to take longer, maybe twice as long for it to show up. And so for us to be able to have this signal that indicates that it might be not working and that the client might not be on track. So this is what I am looking for research on right now, and having difficulty because there's not a lot of research. I know a lot about the outcome rating scale. It's more the PHQ-9, and people who are in my group, right? They've got their stories about the ORS. I'm looking for stories about the PHQ-9, if anyone has them. And so I don't know, you want to give them?
Yeah, so if anyone listening is using the PHQ-9, is that what you're interested in? Using it as a tool for outcome monitoring, get in touch with Cindy.
Yeah, I'd love to hear your story.
Yeah, great. So I'm interested. I know the feedback informed treatment guidelines. We see them on our Facebooks that they're coming out. You said you were reading them. I have not been privy to them yet. I'm interested. Where do you think this is going? What's changing about feedback informed treatment, if anything? Or what do you think is next?
Well, yes, I haven't read. I just got it today.
Oh, cool.
So I haven't read it. And so I don't really know. I mean, for me, I'm into we need to adapt to the system, right? And so I think it's important that we keep using the ORS and SRS. And I know in some countries that this is working, but in other countries it's not. And that we start having 2 measures at least per person for their outcomes. Because then we can work with the system that asks for the symptoms, or whatever their assessment that they need you to do. But you can also do this, and that this is going to give you a lot more richer, actionable information. And that if everybody did that, I also think we could get to the point where we would say we don't need the other ones.
Mm-hmm.
Right?
Yeah.
if you need you want to use a psychometric assessment on someone, right? To help diagnose them, if that's helpful for you in your practice, that's great, right?
Hmm.
But I don't think most of the tools, they weren't really designed to do what the ORS and SRS do, right? If you want to do feedback informed treatment, they're what you should be using, or things like them, right? That are not symptom based and that include an alliance measure.
Yeah. And one of the things Scott said to me when we were doing some webinars together, we had a slide where Scott said, the client's engagement in the service it predicts your outcome. And then the alliance predicts the engagement. And one of the things I mean, all of us are in this to do relational work with people. And then at the same time, the research is pretty clear for over 30 years that we're not really that good at knowing what the other person is thinking about us. And so the alliance measure helps us to predict that engagement. And you brought this up earlier that the study that if you can get a low alliance rating in session one, it indicates you created a safe place for them to tell you what they didn't like, and then you can fix it. And so it's an interesting it's really important that we have that time to understand the alliance and um, uh, get the client's perception of that. Do you think, I mean, with how well the SRS, the session rating scale, and the outcome rating scale work together, and they're so simple and easy to use, um, do you think people have a harder time implementing both of them or just picking one? I know like that's like not the go-go for it, but like, do you think that the session rating scale makes more sense to therapists or than measuring outcome that way?
Uh, I think I wouldn't say that it's one or the other. I've definitely seen both,
Okay.
right? And also quite a strong pushback that the session rating scale should not be completed at the end of the session.
Right.
It can be completed at the beginning of the next session or when they're at home.
Mm,
And yes, and that's, you know, again, I mean, it's all about developing that culture of feedback. Because if we're afraid to, especially young people, right? They'll give that really low score. If we're
mm,
afraid to like get into that, how can we get into their other stuff? Like so to me, my thing is when someone gives you a low score, like a signal, right? One of the subscale scores is lower, and you acknowledge it and maybe address it, like they said that you didn't seem to be paying enough attention to them, right? You ask them about it and they'd like you to like nod your head more, right? And
mhm,
so you say, okay, I'll do that next time. You might not have solved their problem that they were coming there to see you for, but you've solved the problem and you acknowledge them, right?
mhm,
So, that's how we strengthen that relationship and keep them engaged and coming back.
mhm. Yeah, absolutely. One of the things I found with my PhD research, and I was interviewing a bunch of young people who had been to different programs, and one of the interesting things is when there were people that had horrific outdoor experiences, but the people that had it was nothing. One of the things that was really interesting is they were the ones who could really talk to the therapist's technique. They kept wanting to talk to me about this, and it wasn't interesting to me. And the one we know this that the ones who had awesome experience, they talk about the qualities of the worker. They don't ever bring up, it was this cognitive behavioral social worker that happened to be outside. They didn't bring up any of that. But the funny thing is, the more ineffective the therapy was, the more they were like, oh, they kept trying to focus on my mother, and it wasn't something. And I went, gosh, wouldn't that information be really nice to know during the intervention?
Right?
Yeah, yeah.
Yeah. Or
It's
again, like at the end of the session before they leave, if they gave you a signal and then they told you that,
hmm
now now you'll get them to come back.
That's right. Yeah, absolutely.
Otherwise they're not, unless they
Yeah.
have to. That's another problem.
Well, yeah, that's absolutely right. And that gets into, I think, one angle, this is a conversation I had with Ben Feynman, Very Bad Therapy, Ben, a few years ago, was that the angle of making this right for the person coming to see you from a social justice perspective, from an anti-oppressive perspective, using a piece of paper that's only for the client to advocate for themselves, to say this is not helping, or this is amazing, or there could be some small changes to this that might help me more. That's an angle I feel like maybe we all haven't shared enough, that this is just about getting it right for that person. And then coincidentally, your outcomes will improve. If you can get it right for those 4 to 5 that aren't getting better, and even worse for the 10 to 20% that are getting worse, you know?
Well, I think part of it is we need to professionalize getting it wrong, right? Um, because that to me, that is part of the problem with the system is that somehow you must be the expert,
Hmm.
right, for them to listen to you. And so, the tension there is they're now critiquing you.
Hmm.
But like the example you gave, critiquing is kind of a tough word. Feedback is a better word. They're giving you
Yes.
feedback,
Yeah.
right?
Yeah. It's so good. We need to professionalize getting it wrong. We might need to get that tattooed. That's a good one.
Okay.
This was a really fun conversation, Cindy. It's nice to really chat with you. I hope that we get to hang out in the Faroe Islands next year. For those that don't know, the Achieving Clinical Excellence Conference, which is the feedback informed treatment conference, that is in the Faroe Islands at the end of April next year. For those that don't know where the Faroe Islands are, it's kind of off the coast of the UK, near Iceland, near Greenland, up there. I have been to Greenland, but not to the Faroe Islands. So when I saw that come up, I begged Scott to let me present, and now you all have to listen to me keynote there. And I guess a bit of a plug about what I'm thinking of talking about is my experience of going from running this small nonprofit for 10 years to a university hiring me and then COVID and going, oh my gosh. And then looking at our course material and going, this is really thin about how therapy works at all. And then being a researcher, talking to people about feedback informed treatment and things, and that we can get stuck, even though student mode, I know what you mean by being open to new possibilities. There's also student mode over preparing. And so this is the snare of preparation. Just start monitoring your outcomes right now. Don't overthink it. Do it and then get someone who knows how to read your data when you've seen 30 people. And then if your data stinks, you could be doing it wrong, or you could stink and then you got to get better. And
The good
so,
news is it's easier to get better if you stink.
yes, that's right. Yeah, that's absolutely right. Cindy, thank you so much for your time. Is there anything you want to add if somebody listens to this who is using the PHQ-9? Is there a way they can reach out to you? You want me to just put Holistic Research Canada in
Yeah,
in
that'd
the
be
notes?
great. That'd be great. They can just reach out to me through the website.
Great. Now, thank you so much. I'm buzzing on feedback informed treatment stuff now. It's so exciting, and to me, I read The Heart and Soul of Change in 2010 and went, oh, this kind of just makes sense. This is what we'll do from now on. Um,
Good.
and for the outdoor people out there, we constantly are up against well, you're the alternative therapy, and you're not the CBT or the EMDR or the psychoanalysis. You're this weird. So when the big kid therapies don't work, then we'll think about the outdoors. And the promise of feedback informed treatment is if you spend a few minutes at the start of your session with an outcome rating scale, a few minutes at the end with a session rating scale, you are free to go mountain biking, do some horticulture, go surfing, do anything you want as long as you're tracking that client progress. And that can be, it's that's the liberating of, it's not about feedback informed solution focused therapy or feedback informed adventure therapy. It's about, is what you're doing with this person, are they saying it's working, and are you catching it when it's not? And that is kind of the wild card of the whole thing. And so it is simple, but it also is wonderful. So it's, I think it's definitely important to our outdoor, our us outdoor weirdos. Um, Cindy, thank you so much. It was such a pleasure to chat with you, and thank you so much for joining us in for Social Sciences Week, which is just an opportunity to rope all my friends into volunteering their time with me. But I will wrap up and end this meeting. Anything else you'd like to add?
Oh, it was a pleasure, Will. Maybe bring me back next year, okay?
Yes, and we'll have we'll be able to understand why the PHQ-9 stinks. Thank you so much, everybody. And for those registered for all of them, we have Stefan at in Australia. It's like after dinner time, like 6 p.m., 6:30 p.m., something like that. So we've got a free day and then an evening presentation. You will be asleep, Cindy. So
I'm, yeah,
yeah.
it's dinner time. All
Thank you
right.
so much, everybody. We'll see you all later.